So in case of T cells, so T cell, leukemia, lymphoma. So these are mature cells, of course. And over here, I want you to know two entities. One of them is Mycosis fungoides. So Mycosis fungoides. And the other one is ATLL. These both are CD4 positive lymphocytes that are causing the problem, okay, that transform. And if you imagine T cells and these lymphomas, remember skin, because they typically invade the skin or start over there. Okay, so it's in the skin. So Mycosis fungoides, it's not a fungus, it's a T cell lymphoma, of course. And you know that it also has this leukemoid counterpart, and that's called Sézary syndrome. Okay, and Sézary syndrome is typical that in blood, so it's a leukemic version. It has a Sézary cells, and these Sézary cells have a special type of nuclei which you call cerebriform nuclei, and that's in tests sometimes because cerebriform, it means that the nucleus resembles a brain. So it resembles gyri. Okay, so remember Sézary cells, cerebriform nuclei. And by the way, Mycosis fungoides has it as well in the skin, but in later stages, you will find these cells as well. Okay, so Mycosis fungoides, remember skin, it's a rash, there's a pruritus. Unfortunately, it's not a fungus, it's a T cell, very slowly growing T cell lymphoma. In contrast to this ATLL, and we talked about it a bit, it's the leukemia lymphoma. It has both forms. Sometimes it's more liquid, so it's leukemia. Sometimes it's more solid, it's lymphoma. It's one entity, but what's important, and that's in the test, it's the connection with a human T lymphocytic virus 1. Okay, so in this, the first retrovirus in 80s, it was discovered, as I told you. And again, it's in the skin, so they're having rash. And typically, what I said already, remember rash with combination with bone lesions. And there's of course, generalized lymphadenopathy. Lymphadenopathy. So if you have this, then it's rather ATLL. It's not multiple myeloma, okay? Multiple myeloma has no rash again and no lymphadenopathy, not in relation to this, but also, not to forget, it's not CD20 positive. That's why it's excluded from the B lymphomas, okay? So these are the two out of the T cell lymphomas I would like you to know. And then we're heading to B cell lymphomas or leukemias lymphomas. B cell leukemia lymphomas. Rather lymphomas, of course, most of them are lymphomas. And over here, I'm going to divide them to pre-germinal center, germinal center, and post-germinal center neoplasms, okay? And I'm going to mention always something interesting about them, okay? So first, let's get to pre-germinal center neoplasms. So these are totally naive cells, lymphocytes, B lymphocytes. And of course, the main and the only interpreter I'm going to mention over here, it's the mantle cell lymphoma. Okay, and of course it's CD20 positive because it's a B cell, it's a non-Hodgkin's. All of them, most of them, I'm going to tell the exception, but all of them are except Hodgkin, non-Hodgkin, of course. And as I said already, this one is connected with cyclin D1, which is increased, and typically this is it's a translocation of part of the 11 chromosome to 14. 14 is the heavy chain locus, so so the cyclin D1 is overexpressed and you're having a mantle cell lymphoma. Over here, because it's CD20 positive, remember T therapy, rituximab. This is like intermediate malignant lymphoma and typically starts in late adulthood, like 60 to 70 years. So remember, over cyclin D1, that's very important. And rituximab pretty much helps it's a proto-oncogene and it pretty much helps the therapy, okay? Then you use an air-chop chemotherapy for the treatment. So that's pre-germinal center neoplasm. That's only one, but then we have many in the germinal center. So in germinal center neoplasms, over here we got, first of all, the follicular one, okay? So follicular lymphoma. So it grows slowly. It's CD20, in many cases it's CD20 positive. So again, you can use rituximab, and this one is connected with BCL2, as we already stated a few times, okay? And this is a translocation of 14 or 18 to 14, but it's a 14-18 translocation. So again, to the locus of the heavy chain, okay? And yeah, BCL2 is an anti-apoptotic protein. It helps the lymphocytes, which are not nice, to survive the apoptosis. And of course, yeah, we talked about the architecture of the lymph node, so I don't have to mention it again. Anyways, the complication of this is very important, and it's a transformation to diffuse large B cell lymphoma. Remember that. And diffuse large B cell lymphoma, it could be mentioned under germinal center neoplasm and also post-germinal center neoplasm. I'm going to come to it very soon. But remember, this is a complication, and typically how does it look like? Normally you have a lymphadenopathy and suddenly some nodes will expand more, or you have a new location. And in this case, this is a impulse that could tell you that the follicular lymphoma has changed or transformed into more aggressive one, which is the diffuse large B cell lymphoma. Okay. Again, of course, you can use, if it's CD20 positive, you can use rituximab in combination with chemotherapy. Another one, which belongs to this group of general center neoplasm, is Burkitt's lymphoma. And over here, you should remember EBV virus and also HIV. Yeah? So with the EBV, with the Burkitt lymphoma, typical mutation is c-MYC. And over here, the translocation is 8 to 14. And as I said, this is transcription factor. And you have two versions. One is combined with EB virus. And typically, it's the endemic form. And typically you see it on a jaw of a small child, 4 to 7 years of age. And this is typically seen in Africa. So endemic version in Africa. And then you have the sporadic form that's abdominal. And this is typically connected with HIV as well. Doesn't have to be, but it is. And in terms of age, it's rather between 10 and 20 years. And both of these, the thing you should remember, they multiply very fast. So the lymph node or the lymph nodes, they multiply in one day. It's a very fast enlargement. Like in one day, it doubles. It can double. So this has a consequences. In the endemic form, it's rather that you can have a compression of trachea, so trachea compression, etc. In terms of, let's say, sporadic form, in the abdomen, you can have a ileus, or you can have even an acute kidney injury because there could be a blockage of the ureters, okay? So mechanically, it can cause a problem, okay? And because it grows so fast, so even without chemotherapy, you can see, and this is typical, and that's one of the best examples of a neoplasm that can cause a tumor lysis syndrome. That means that the necrosis of the cell is so fast and so huge that you can have a hyperkalemia, you can have a hyperphosphatemia, you can have a hypocalcemia, and you can have lots of uric acid, and this can kill your kidneys as well, so acute kidney injury. And over here you can have arrhythmias and for example, epileptic seizures. Okay. So watch out, even without chemotherapy. Typically, you see tumor lysis syndrome after chemotherapy because there's a necrosis of the cells. But in case of Burkitt lymphoma, the cells multiply so fast, so they also die so fast. So you can have a tumor lysis syndrome even without chemotherapy. Okay. And the other one, of course, if I want to make it complete, remember that ALL and AML, they multiply as well, but you don't see it as commonly as in Burkitt, okay? Also in acute leukemias, yeah, you can see a lysis syndrome, tumor lysis syndrome, even without chemotherapy. Otherwise, you see it typically with chemotherapy because this is an impulse that kills many cells, okay? So that's Burkitt's lymphoma. Remember, of course, starry sky, that's pathology, but yeah, we can mention. So it has a starry sky appearance. So that was Burkitt's lymphoma. And let's get to another one, and that's the diffuse large B-cell lymphoma. So diffuse large B-cell lymphoma, again, there's a rapid growth in lymph nodes, in spleen, in liver, in bone marrow, okay? So growth in lymphoid tissue. And typically it could be a transformation from actually two of them, but in this case, because it's a germinal center, now we put it under germinal center, we can put it also under post-germinal center. So in this case, typically it's a transformation from follicular lymphoma. But also it could be de novo. But in both of the cases, so de novo or transformation from CLL, rather it's going to be post-germinal. I'm mentioning it here, but maybe I'm going to mention it in the post-germinal. So, and remember, the de novo is typically connected with HIV. So de novo mutations is connected with HIV. Okay? Yeah. So that's the diffuse large B-cell lymphoma and still Hodgkin. So Hodgkin lymphoma. So thanks for watching. And don't forget to subscribe and ring that bell. And as always, check the description below for supplementary questions and other materials.